Good morning. I hope you're all doing well and you had your coffee and ready to go for our presentation on COPD. I'd like to thank the organizing committee for the kind invitation. Privilege and honor to be with you today. Without further ado, let's start talking about COPD by presenting the definition of COPD put together by GOLD, Global Initiative for COPD. And they say it is a common, treatable, preventable disease that is characterized by certain symptoms which are kind of persistent, unlike asthma. And the pathognomonic feature is airflow limitation, which could be easily diagnosed in the pulmonary functional lab, obviously. And that resulted from pathophysiological changes and histological changes that take place not only in the airways, but also the alveoli, the parenchyma, vasculature of the lungs, and even spells out to many other organs. That's why we say COPD is a syndrome, a systemic disease, rather than a limited disease to the airways or the lungs. And this all happened because of continuous exposure to noxious particles or gases that stimulate an ongoing inflammatory process in the lung parenchyma, and then the lung changes into a kitchen brewing all these inflammatory cytokines and chemokines that affect the rest of the body. Why is COPD so important? Why do we talk about COPD every single year? Because it is now becoming the third global killer and continues to rise in prevalence and incidence. That's why we heavily lean on the primary care physicians to be the frontliners in making the diagnosis, suspecting the disease when someone presents to them with the classic symptoms of cough, sputum production, especially if they are over the age of 40 with the classic presentation and exposure to noxious particles. On top of the noxious particles is obviously cigarette smoking, whether primary or secondary smoking, but keep in mind also there are environmental types of exposures. Not everybody who smokes gets COPD. That is a fair statement. Some people smoke and don't get it, and only about 20% of smokers do get COPD. Now, the whole thing that characterizes COPD is the narrowing of the lumen secondary to hypertrophy of the airway wall, also plugging of the lumen. And eventually we end up with a very tight airway that limits the ability to exhale, and that's why we always have air trapping in the lungs and increased diameter of the chest. There is hypertrophy of the mucus cells, and it is not surprising that those patients have a lot of mucus and plugging of the airways, which is part of the problem. If you take a histologic cross-section of the airways, you'll find that the pathology spreads from the lumen all the way to the outside of the parenchyma, involving the wall's hypertrophy, like we showed before, the hypertrophy of the mucus-forming cells, so the muscularis layer is also hypertrophied, and there is intense inflammatory changes that take place outside of the airway. And mostly neutrophils are a major player, although you will see eosinophils and lymphocytes as well. And asthmatics usually have a lot of eosinophils, COPDers have neutrophils. So we call COPD a neutrophilic type of inflammatory disease. The slide here shows the difference in structure between a nice normal looking lung and a lung with COPD. Over here you have a bronchitis type of change with a thickening of the airways and the intense inflammatory reaction, peribronchial, and here destruction of the airways leading to the development of emphysema. Now in this little movie here, it shows you the changes from the nice looking acini with gas exchange at the capillary bed and how that turns into a destroyed type of alveoli over distended with the destruction of the capillary beds. And it is not surprising that patients develop hypoxemic and hypercapnic respiratory failure. This is to show that the vasculature is also affected in COPD. We have a protective mechanism called hypoxemic vasoconstrictive reflex, the basis of which is that areas that are under-ventilated, under-oxygenated should not be perfused. So when you have hypoxemia in a certain part of the lung, there's also vasoconstriction that follows. And as you increase your vasoconstrictive reflexes or process in the lungs, you develop pulmonary hypertension. And that obviously reflects on the right side of the heart and the right ventricle hypertrophies to be able to pump blood through this high resistance circuit, with the development of right-sided heart failure with JVDs and pedal edema, as you see. As we said, it is an intense inflammatory process involving so many inflammatory cells and cytokines, which are not limited to the lung itself, but also spells out to affect other organs. And as you can see, there is a lot of comorbidity that develops with COPD. So COPD is really a systemic disease, not just a disease of the lungs. Going back to the pathophysiology that happens in the ventilation process, we have air trapping because the patient's not able to exhale all the inhaled volume and they're not able to empty the lungs completely, so they end up with these hyperinflated chests. You, as a primary care physician, should be suspecting patients having COPD when they present with the classic symptoms of cough, sputum production, limitation of airflow, and limitation of exercise. Now, the diagnosis will have to be made in the pulmonary function lab, and what you're looking for is this post-bronchodilatory persistent type of airflow limitation. And it is diagnosed by finding that FEV1 to FVC ratio is less than 70%, as you know. And this simply means that you're not able to blow off the inhaled gases within the first second, at least 70% of it. If you don't have an obstructive process, you should be able to get out 70, 80%, even 90%. Sometimes even the whole breath can come out in 1 second. Like if I take a breath like this, I'm able to breathe it out in less than 1 second or 1 second, so shouldn't have a problem. Someone who takes a breath in and unable to get at least 70% out of this volume in the first second has an obstructive problem. Like, for example, taking a breath in and then taking the time to breathe it out. This is what we see on the pulmonary function lab, flow volume loops, and we don't have a lot of time to go through the details, but I just want you to recognize this pattern here of the concavity and the expiratory limb. This is inspiration, this is expiration, and if you see this in the exam or boards, then you know this is an obstructive airway process. We can also measure lung volumes by dilution technique. We allow a gas to get into the lungs, and by changing the concentration 1, concentration 2, volume 1, volume 2, simple equation, we can calculate lung volumes. The only limitation is if you have atelectatic areas in the lungs that do not allow the gas to get in, these areas will not be counted in the calculation, and the whole method will underestimate the lung volumes, which can be more accurately measured in the plethysmography lab through the body box. And the way it measures lung volumes is by measuring pressure inside the airways versus pressure in the box, and then the patient will start panting, so it'll be change in pressure, and you get pressure 1, pressure 2, volume 1, volume 2, and this is how you can also solve the equation and get the volumes of the lungs, which is more accurate because it doesn't depend on the gas getting into lung areas. We can also test the efficiency of the capillary alveolar membrane diffusion capacity by measuring diffusion capacity of carbon monoxide. Now, we have a pretty good idea in the pulmonary function lab what we're dealing with, but if you happen to get radiographic images on the patient, it can also give you some clues. I'm not advocating that we do images to diagnose COPD, which is obviously diagnosed in the pulmonary function lab, but if you do happen to pursue images for other reasons, looking for pneumonia, cancer, atelectasis, PE, whatever, then you will find classic findings on radiographic images of increased AP diameter, the flat diaphragms, and increased retrosternal lucency, the hyperinflated, long elongated lungs reaching all the way to the 11th or 12th rib. And if you happen to do a CAT scan, you might find emphysematous changes like these ones. The pulmonary function lab is very important in confirming the diagnosis, number one, and also in diagnosing severity of disease. Now, Gold had put certain criteria and cutoffs for the severity of disease. Obviously, if you're still able to blow off 80%, if you're not able to blow off 70% of your inhaled volume, FEV1 to FVC is less than 7%, that means you have an obstruction problem. And if your FEV1 compared to a normal person that has your height, age, and weight and everything, so it is expected of you to have a certain FEV1. If your current FEV1 compared to the predicted value is more than 80%, then your disease is mild. Below 80, that you're moderate. Below 50, you're severe. Below 35%, you are very severe. How is that important? In the old days, we depended a lot on this classification, the gold stage, to determine therapy. Nowadays, we are shifting more towards clinical and symptoms-based model, measuring symptomatology and the risk for exacerbations. To assess symptomatology, we consider dyspnea the main symptom based on which we will prescribe medications. So we are familiar with the old method of dyspnea classification, New York Heart classification, and now we have the MRC, or the Medical Research Council, which came up with a very similar system to measure dyspnea. And dyspnea, 3 level, when you are walking slower than others and you get short of breath with minimal activities, that puts you at increased risk. So MRC more than 2, like 3 or 4 or more, that means you're very symptomatic. The CAT score has to do with the cough, sputum production, losing night sleep, losing days of work, losing confidence because of your COPD. So if the CAT score is more than 10, then you are very symptomatic. And based on those 2 elements, we have the symptomatology and we have the risk of exacerbation, meaning more than 1 exacerbation, 2 or more, makes you one of those who have increased risk for exacerbations. And exacerbation simply means any alteration in the course of the disease requiring an intervention. Even if that intervention does not require hospitalization or ER visits, even if you have to change your therapy, upgrade your therapy, start prednisone taper, start antibiotics, any of those interventions would qualify that change to be an exacerbation. If you get 2 or more of those, then you have increased risk for development of complications. So on the vertical axis, we have the exacerbations and the GOLD criteria. And on the horizontal axis, we have symptoms. Either MRC or CAT score, doesn't matter which one you follow. Going to the right is more symptoms, and going up is worse GOLD stage and more exacerbations. So we're going to be dividing our patient into 4 different categories, and this category here is the best, and that category is the worst. This one has the least symptoms and has the best GOLD criteria, class 1 or 2, which means mild to moderate disease, and also doesn't have a lot of exacerbations. So this person is obviously the worst one, who is having a lot of symptoms, a lot of exacerbations, and stage 3 or 4 GOLD. These 2 people have controversial findings. This person has a lot of symptoms, but not too many exacerbations, and GOLD mild or moderate. And this person is looking bad in the pulmonary function lab, GOLD 3 or 4, with more than 2 exacerbations, but not necessarily very symptomatic. And we'll talk about therapy. We understood that COPD is a very puzzling disease. It's rather a syndrome. COPDers, although they might be in the same category of GOLD criteria, moderate, mild, or severe, but clinically they look different. That's why we recognize that COPD has different phenotypes. And in the old days, even in school, we were taught that COPD has these 2 distinctive phenotypic patterns. One is pink puffer and one is a blue bloater. And you remember that from old school, that the blue bloater is the one who retains CO2, lazy, obese, sitting down, narcosed most of the time. And the pink puffer is huffing and puffing all the time. And they are pink because when they breathe, they bring enough oxygen to make them pink. But now we recognize that we have so many phenotypic patterns. Those who develop cancer early, those who develop pulmonary hypertension early, those who are on the fast track to emphysema, and so forth. So there's a lot of phenotypic presentations for COPD. Now, the question is, how are we going to manage COPD for stable patients? So I'm not talking about COPD exacerbation when they come to the hospital. I'm talking about COPD patients who come to your office. So the management strategy, what are the goals? What am I trying to do for the patient? Number 1, improve the health status. Number 2, reduce the risk. Improving health status will have to involve reduction of symptoms and improve the exercise tolerance, so the patient is not coughing as much and the patient is able to do more for himself and for his family. Reducing the risk of what? Of mortality, complication, getting sick, hospitalizations, all these things. So what can we do? There's a lot of things that we can do, as I will explain in a few minutes. First of all, prevention of the disease by stopping smoking and exposures, immunizing the patients so they don't get sick. Number 3, the mainstay of treatment is going to be inhaler medications. And then we have non-pharmacologic interventions as well, oxygen therapy, pulmonary rehabilitation, diet, nutrition, all these things. And then when things get worse, we also have some interventions that involve bronchoscopic interventions and even surgery, like lung volume reduction surgery. We start with the simple things, which is not as simple to convince patients to quit smoking. Only 20% or even 15% of people who quit smoking actually can sustain that, and many of them go back to smoking, unfortunately. But use whatever tools you have to try to convince the patient, whether it's religion, psychiatry, group therapy, anything. And also, we have a lot of medications now to help remove the addiction by nicotine replacement therapy, gums or patches. We also have antipsychotic medications that help the patients reduce their urge to smoke, like bupropion and Chantix. I would say one of the main or the most useful things we can do for COPDers is have them quit smoking, because only smoking and long-term oxygen therapy can alter the course of the disease and improve mortality. Everything else is just treating symptoms. And like we said, our treatment is going to depend basically on inhaler medications. In the old days, we had oral bronchodilators, and that's now obsolete. We don't use it anymore. And medications can actually improve the quality of life, reduce the symptoms, reduce exacerbations, but they will probably not alter the mortality or course of the disease. We have two classes of medications, as you know, and the whole idea is we want bronchodilation. I want to open up the airways. And how do we do that? We found the receptors called beta agonists, and we can stimulate those either with short-acting medications, short-acting beta agonist, which is SABA, or long-acting beta agonist, which is LABA. And some of the side effects include sinus tachycardia and some tremors. Now we have different muscarinic receptors, which are acetylcholine type of receptors. And stimulation of those receptors leads to bronchospasm, contraction of the smooth muscle. So we like to block those receptors. So we call them muscarinic antagonists. And if you have short-acting muscarinic antagonists, we call them SAMA, S-A-M-A, like ipratropium. Or we have long-acting muscarinic antagonists, like we call them LAMA, like tiotropium. And the side effects of those class of medications are just like atropine, dryness of the mouth, and retention of urine, especially in patients who have prostatic hypertrophy of the prostate. So it's a good idea to combine these medications, because obviously patients will not be compliant if you give them so many medications, beta agonists, muscarinic antagonists. So we put them in one canister, so we can combine either short-acting together or long-acting together. So the combination of the short-acting beta agonist, short-acting muscarinic antagonist is the Combivent, which has salbutamol and ipratropium. And the long-acting medications also together, LAMA and LABA, like formoterol and tiotropium. But we have so many of them, available in the market. And it was shown that the effect of the combination LABA and LAMA is much better than using a single agent. Now, how about using inhaled corticosteroids for COPD? Obviously, it's been very successful in asthma treatment. And we said just a minute ago that COPD also has a lot of inflammation of the airways. So the theory is, can I use inhaled corticosteroids as well and expect some response like we do in asthmatics? And actually, the studies were disappointing, because there was actually increased mortality. And so it was deemed that ICS for COPDers is not a safe medication unless you combine it with LABA, long-acting beta agonist. And that's a combination that could be used, but don't use ICS alone in COPD. Lots of formulas available, a combination of medications, and I summarized the evidence from the literature for you. There is strong evidence now that the use of regular medications, inhaler medications, would help COPDers. Whether you use SAMA or SABA, any combination works better than any single agent. We prefer the LAMAs, or the long-acting muscarinic antagonists, over the LABAs for COPD. It might be a little different in asthmatics, but COPD, we like the antimuscarinic medications better. Tiotropium is a great drug. It reduces exacerbations and improves lung functions. And theophylline does have some bronchodilatory effect, but we are kind of hesitant to use theophylline because of its toxicity, especially in someone who has cardiac history or cardiac arrhythmias. Now, we are also looking for other receptors to block, or to stimulate, like the beta agonist and the muscarinic antagonist. So the more receptors we can work on by finding other classes of medications will be better. And we did find the prostaglandin E4 receptor. So by inhibition of this phosphodiesterase inhibitor, roflumilast, which works on a lot of the inflammatory cells involved in the process of COPD, and it has been very successful. It reduces exacerbations and improves lung function and overall quality of life. But who gets it? Obviously, someone who has not responded to the classic pathway of therapy after they've been tried on pulmonary rehabilitation, triple therapy with inhaled LABA, ICS, Nevertheless, they do have a lot of exacerbations, and those are the ones who are suspected to have a lot of inflammatory changes that might respond to roflumilast. The only problem is roflumilast is not well tolerated because of side effects. Now, the algorithm, how are we going to decide who gets what, which patient gets which treatment? Like we said, we divided our patients into 4 different categories, and obviously this patient here has the least amount of symptoms and the least severity or exacerbation, so he's going to get away with probably SAMA or SABA or a combination of both. So short-acting medications for this group of patients will work fine. Now, this patient, to make it easy for you, this is the worst patient who's going to start on intense therapy. Intense therapy means long-acting medications from the get-go. So you start on a LAMA and you combine. You can combine LAMA-LABA or LABA-ICS. And if it doesn't work, you go to triple therapy, LABA-LAMA-ICS. And this is a patient who might not respond to you, so you're going to use some non-pharmacologic interventions, especially pulmonary rehabilitation, maybe even oxygen. And this is the patient you're going to be considering for roflumilast. Now, this patient who has a lot of symptoms, but not necessarily looking worse or bad in the pulmonary functional lab, doesn't have a lot of exacerbations, you're going to start the LAMA. And if not, well controlled, you can combine either LAMA-LABA or even LABA-ICS, because you think maybe all these symptoms are manifestations of ongoing inflammation, so the use of ICS in this particular group is useful. Now, this patient in group C, this is the patient who doesn't have a lot of symptoms but has advanced disease by Gold criteria and maybe 2 or more exacerbations per year. And those ones are also going to be started on LAMA. And if not controlled with one medications, you can combine LAMA and LABA. And as you will see, this is group A, this is group B that has a lot of symptoms, and this is group C that has a lot of exacerbations, and this is group D. This is the person who needs the most intense therapy. Now, keep in mind when you're prescribing these medications that you have to consider patient's preference. Some patients are so adamant about medications that you would or would not take. And also you have to keep in mind the cost of the medicine. It doesn't really help when you prescribe the medicine if the patient will never buy it and never use it. That's why when they come to the office for follow-ups and they tell you they're not getting better, you really have to ask them questions. Number one is, are you taking the medicine? Are you adhering to the medicine regimen, and especially long-acting control medications? And number two, they should demonstrate to you the technique they're taking the medicine, because a lot of patients, you'll be surprised, do not use good technique, and the medicine never makes it into the small airways. Now, is it a good idea to use long-term oral corticosteroids for patients with stable COPD? The answer is no. We have strong evidence that we have a lot of side effects, and we have weak evidence that there's no benefit. So why would I use a medicine that has no benefit and has a lot of side effects? That doesn't make sense. Mucolytics in some patients who have a lot of mucus and plugging of the airways could be beneficial. Some of the statin and all the statins do not help in COPD. Yeah, there was maybe a few years ago, there was a talk about statins being anti-inflammatory, should be helpful in COPD, but that didn't prove to be right or correct in literature or in the trials. Leukotriene modifiers have not been studied extensively or efficiently or enough in COPD, so no judgment can be made about the use of leukotrienes in COPD. Can I treat pulmonary hypertension that develops secondary to COPD with medications that were designed to treat primary pulmonary hypertension? The answer is no. These patients will not benefit from those medications. Opioids are great because they alleviate the symptoms of dyspnea, anxiety, and panic. Now, I have to be careful with patients who use a lot of shorter-acting rescue medications at the expense of using the long-acting medications, which means that the patient's symptoms are not well controlled. And if the patient is reaching out for the rescue medicine more than twice per week, that means he is not well controlled, and it's something we need to discuss in the office. Antitussives are not recommended. The use of antibiotics not as antimicrobials, but as anti-inflammatory. Like those patients in the box number D, when they have a lot of symptoms and exacerbations, you could try anti-inflammatory medications, whether it's roflumilast or long-term use of macrolides, azithromycin, or clarithromycin, but you have to be very careful with the development of resistance to antibiotics. Now, those who have alpha-1 antitrypsin deficiency, is it worth giving them commercial replacement therapy? Yes, it is, especially if they have emphysema already or development of emphysema is expected, and if they have severe deficiency below a certain level. Pulmonary rehabilitation is a great tool. non-pharmacologic intervention, it really helps improve the quality of life overall. It reduces exacerbations. Patients do not end up in the hospital all the time. They feel good about themselves. The exercise capacity is also improved. Oxygen therapy is one of the two things that can actually alter the course of the disease and improve survival. But you have to use oxygen more than 16 hours per day to get the full benefits. So oxygen therapy and quitting smoking are the two things that can actually alter the course of the disease. Non-invasive positive pressure ventilation has become now part of the therapy. So if you use it at home, you can keep patients at home for longer periods and save them certain hospitalizations and admissions through the emergency department, especially for those who have hypercapnia or combination of COPD and sleep apnea. It has become standard of care when patients come to the hospital with exacerbation of COPD. Non-invasive positive pressure ventilation saves patients intubation until you buy some time for a day or two until the bronchospasm goes away. And the two approved indications for NIPPV is exacerbation of COPD and congestive heart failure. Now, if none of that works and the patient is still symptomatic, then you might think about some more interventions. Surgical intervention like lung volume reduction surgery, the whole idea is to get rid of the non-functional, over-distended part of the lung and replace it with the healthier tissue underneath that is given a chance to expand and do a better job. And it's very successful when you have bullous disease or big dead spaces in the upper lobes. So when you cut those off, you get the best results. Obviously, it improves your exercise capacity, the overall life, and reduces symptoms. So it is worth looking into. If the patient is non-surgical candidate, the patient doesn't want surgery for whatever reason, then you can try to do the same thing or accomplish the same thing bronchoscopically by putting in a valve, one-way valve that allows air to get out of the part of the lung and not allow the air to go back in. So this part of the lung is going to collapse. So if you put it into a bronchus leading to a big bullet and deflate the bullet, it will be as effective as if you're taking it out surgically. This is what the valve looks like, and this is the deployment of the valve bronchoscopically, and the valve is in here allowing the gas to get out and not get back in, like we said. Now, if that fails, then you need new lungs and lung transplant. This is a whole topic in itself. We cannot discuss it here, but I would like to say that referral of the patients early on before they're actually dead, when they can still withstand surgery, is a good thing. So when you see FEV1 dropping like below 30%, that's the time to refer patients for consideration lung transplant. If there is nothing else you can do for the patients, then still palliative care is showing compassion and concentrating on making patients comfortable by providing them with like opiates, oxygen, still continue medications, treat their anxiety, their panic, their depression. Don't forget depression and COPD. A lot of people would assume that COPD patients are not eating because they are short of breath and they don't have the ability to eat, but obviously depression is one of the things that can stop people from eating and be interested in life. Don't forget November 16th is the COPD day, and today is, you probably listened to the presentation November 23rd or 24th. We're still in the month of COPD. So be vigilant. We depend on primary care physicians in making the diagnosis and making the difference in the life of patients with COPD and in society in general. Thank you so much.